Today I hope to discuss some innovative strategies for managing opiate use disorder. And while my talk is titled Beyond Safer Supply, it may be more apt to say including safer supply. Like methadone, Sublocade, and Suboxone, every intervention I'm going to discuss is a safer alternative to the toxic drug supply. The toxic drug supply, as you guys know, has been killing our patients, our friends, and our families. And I don't, for one, believe there's a moral difference between which opioid molecule we choose to use to treat our patients. And that belief in the amorality of opioid molecules underlies my presentation today. So for my disclosure, I am a contracted consultant to the Works program at Toronto Public Health. I do discuss our OUD program in this talk, which employs one of a range of tools for addressing treatment-resistant opioid use disorder. And just so you know, this talk is probably aimed for people who are experienced prescribers in opioid use disorder and who treat patients that are resistant to treatment or who have failed more traditional treatments. So today I plan to briefly address the controversy and the evidence around safer supply. I'll also describe our IOUT program and some of our outcome data. And then I'll move on to other approaches that are accessible to every clinician today. I'll end with a brief tip of the hat to the innovations by Dr. Sutherland in BC, and I'll discuss briefly her paid fentanyl program. But first, I wanted to address the elephant in the room, safer supply. Nothing can get a group of nerds riled up quite like a discussion of safer supply can. So let's just jump right into it. I'm going to try to do a poll question. So we could have the first poll question up. There we go. So for people who are there, oh, there's one poll question. Yes, this is the one. This is the one. If you guys could take a minute to figure out how to answer this. And the question is, do you have at least one person, perfect, to whom you prescribe take-home hydromorphone as a treatment for opiate use disorder? So there's 28 of you. Let's see how it goes. Are you able to find how to answer? We'll wait for a few more answers. We only have 3 responses of 28 people. And I can tell you my answer to this is yes. I do have at least one person to whom I prescribe take-home hydromorphone. Okay, we got more people figuring out how to answer. Doing great. We've got 7 out of 30. Okay. Thank you, Elisa. I get you're not a prescriber. Are a lot of other people not prescribers here? Okay, same. Okay. Okay, interesting. Okay, so we've got 8 prescribers. Can people put in the chat if they're a prescriber or not a prescriber? I've got 3 people not prescribers, and so far I've got 9 people answering. Okay, a lot of people aren't prescribers. Okay. Okay, that's good to know. Okay, I hope I don't bore you to tears with this chat because it is a bit prescribing heavy, but I'll try to. Anyway, you'll be able to influence the prescribers in your circles after this chat. Okay, so of the prescribers, of which a third of you are prescribers, we've got twice as many people who don't prescribe safer supply as people who do prescribe. Thank you. Who do prescribe safer supply. So I'm loving your comments in the chat. By the way, I really hate presenting on Zoom, so please continue to comment. Okay, next poll. There's a poll after this that I want to do. Yeah, if you don't prescribe safer supply, so this is for the 6 people. And actually, non-prescribers, if you work with prescribers who aren't prescribing safer supply and you know why they're not doing it, You can answer this question too. You don't have to be a prescriber. So I'll give you time to look at the answers. So 1, I'm worried about diversion. 2, I don't think there's enough evidence to support it. 3, I'm worried about being criticized by my college or by my peers. 4, I tried it and it didn't work out. And 5, my group practice doesn't support or allow it. 6, other, F, other. Let you guys think about that. If I were to choose my true answer to this question, I think it would be C, is the biggest reason why I am reluctant to prescribe safer supply. I'm worried about being criticized by my college or my peers, particularly my peers, more so than my college. Somebody else agrees with me. After that, it would be followed by 4. I've tried it and it didn't work out. I try it. I have a few people on it right now. And it often doesn't work out for reasons that I will discuss in a bit. And my third biggest reason is that I'm worried about diversion. For me, that pales below that I'm worried about being criticized by my peers. Okay. Next slide, if we could get back to the slide. Thanks. And then we'll go one slide further. Oh, I get to do that. Page down. Okay. So it's not just peer pressure that makes me nervous to prescribe safer supply. It's also social pressure and other kinds of pressure, political pressure, media pressure. Safer supply and abortion comprise 2 of the few medical treatments that we have that are topics of political debate. And the speakers this morning discussed this quite a bit. The misinformation really is rampant. So this is Pierre Poilievre in the House of Commons last year when he put forward a motion to defund safer supply. This is what he said. He said, Trudeau's policies are flooding the streets with drugs that now go for $1 a hit. You can buy 26 hits of hydromorphone, which is an analog to heroin, for $30. These are drugs paid for by Canadian tax dollars under a program by this government that has led to a 300% increase in overdose deaths. Why won't they get some common sense, end dollars for drugs, and put our people in treatment? There's so much wrong with this statement that it's hard to know where to begin. First of all, 26 hits of hydromorphone is about 200 milligrams of hydromorphone, which is exactly equivalent to 1 dose of the OUD that we prescribe at Toronto Public Health, or approximately equivalent to 2 points of fentanyl, not 26 hits. So that's wrong. But more importantly, Poilievre is implying, or in fact stating, that safer supply has caused a 300% increase in overdose deaths. Of course, we know this couldn't possibly be true. This is just false. It's the increased potency and contamination of street fentanyl that has led to these deaths. So what scientific evidence do we actually have about safer supply? Well, as many of you know, there's been a considerable amount of high-quality evaluation of safer supply, which in my opinion has demonstrated that participants in safer supply benefit. A recent BMJ paper found a significant reduction in all-cause mortality and also overdose-related mortality in the week after receiving a safer supply prescription, and that's after controlling for the receipt of OUD, or oral agonist therapy, methadone, Kadian, that type of thing. Dr. Tara Gomes and others demonstrated a reduction in ER visits, hospital admissions, and healthcare costs. And the initial criticism of safer supply was that it would cause infections like endocarditis and cellulitis and abscesses. But Dr. Gomes' research, which was an evaluation of the London program, didn't see this borne out in the science. There was no significant change in the rate of infections. There have been many qualitative evaluations of safer supply programs across Canada, and they've invariably showed improved physical and mental health and quality of life of the participants. So what is with all the drama? Well, there are suspected harms, diversion. People are very worried about diversion. I think we remember our role in the 1990s and in the 2000s when our vast overprescribing of oxycodone contributed to skyrocketing rates of opiate dependence, and we don't want to repeat our mistakes. This does make a lot of sense, but the context today is much, much different, and we have to acknowledge that. With oxycodone, we were widely prescribing opiates to people who were opiate naive. Safer supply providers are on a much smaller scale, providing opiates to highly opiate-dependent individuals who are dying at an alarming rate from a poison drug supply. While it's hard to measure how widespread diversion is, there are some reassuring indicators. The RCMP, in their evaluation of drug seizures, have found no evidence to support a widespread diversion of safer supply drugs in the illicit market in BC or in Canada. Conservative politicians and journalists are raising fears about hydromorphone pills getting into the hands of children and causing overdoses. However, there's no evidence that diverted prescriptions are increasingly causing overdoses in children. Indeed, there was a significant decrease in the involvement of opioids indicated for pain as direct contributors to death among adolescents and young adults. And this was largely influenced by less hydromorphone and oxycodone involvement. This is from a Public Health Ontario report using coroner data. However, while we know it might not be widespread or causing increased overdose in children, we do know that diversion is happening, and there are ways of prescribing that can minimize it. So let's discuss alternative ways that we can provide safe options to the poisonous street drug supply while also minimizing the risk of diversion. The first alternative is simply observing safer supply prescriptions, or at least observing some portion of them. This will work best with individuals who are not injecting their medication. The South Riverdale Community Health Centre in East Toronto is located across the street from one of the clinics that I work at. Because of the instability of their funding, they've been forced to move their patients out to other prescribers. We've taken on some of their patients, but the providers in my practice, including myself, are less comfortable providing the 30 take-home tablets a day that some clients have been receiving. Without making dramatic changes quickly and destabilizing clients en masse, we've been working with clients individually to move towards providing a portion of their prescription as an oral dose observed in pharmacy in the morning. My agreement with my colleagues is that we would feel comfortable providing about 10 take-home Dilaudid a day rather than 30. And so we're slowly maximizing clients' OAT, increasing the observed portion of their Dilaudid, and reducing their take-home dose to a smaller number of pills. We'll see how it goes. For those who inject their tablets, we could look at making arrangements with the SIS across the street and have the tablets delivered there for observed injection. Finally, and more simply, we could treat take-home doses of Dilaudid the same way that we treat take-home doses of SROM or Cadian, sustained-release oral morphine, and methadone. So we could ask for urine drug screens that are positive for the drugs we're prescribing and negative for illicit drugs, and then we could assess patients' functional stability and prescribe carries. We know safer supply benefits those who receive it, so why throw out the baby with the bathwater? The bathwater being diversion in this case. Another evidence-based approach is IOUD. IOUD is injectable opioid agonist therapy. Unfortunately, this is much less available and accessible to our clients. But because we should advocate to improve its accessibility, I thought it would be worth mentioning today. And just to answer a question in the chat, 10 tabs is 80 milligrams of hydromorphone, which is not actually a very high dose. It's probably less than 1 point of fentanyl. I'm just going to review some of the benefits of IOD. There's been a considerable amount of very high quality research looking at the effectiveness of IOD for opiate use disorder, including 2 Canadian RCTs, and also a systematic review. So Banerjee and Wright in the systematic review compared the effectiveness of IOD treatment to methadone alone and found that clients in IOD programs had better retention, fewer criminal offenses, better mental and physical health and well-being, increased quality adjusted life years, and decreased healthcare costs. These studies weren't powered to find differences in mortality, and they did find no significant differences in mortality. There are more harms associated with IOD, more adverse effects, including sedation, histamine reactions, seizures, and non-fatal ODs. In our program at The Works, which is located in downtown Toronto, we were funded by a federal SUAP grant, so long-term funding is very uncertain for the program. We give injectable hydromorphone along with optimized OUD, or oral agonist treatment. And our program includes wraparound services other than primary care. We link people to primary care, but we have services like case management, counseling, and referrals. And our team includes peers, nurses, and counselors. This is not a carry program, so all doses have to be observed. And by the way, for people located in Toronto, we are currently accepting patients, and all people have to do is show up to IOD during clinic hours and we'll assess their eligibility. Basically, in order to be eligible for the program, you need to be regularly injecting street fentanyl and not be in a place where you really want to stop injecting at this moment. The way it works is we order the medication directly from a pharmaceutical supplier. The medication itself is paid for by the SUAP grant money. We have extensive safety and monitoring procedures in place, and we observe clients injecting, and we observe them before and after injection. There's no opportunity for diversion at all. There's a question in the chat, is IOD also available as monotherapy? As I'll show you, we have only one person who is on IOD alone. And the reason is the hours of our clinic are short. So people tend to need something long-acting overnight to keep them, because we close the IOD clinic closes at 4 o'clock. So they need something for the evening and the night. An OHIP card is not required for eligibility. They can come in without OHIP. Same with, just so you know, we have, I think, possibly one of the only methadone programs where people don't need OHIP. So we actually see people, we have a lot of people who aren't here legally. And if you have clients in Toronto that are not able to access care because they are illegal, or just their OIP has expired and they haven't been able to get it together to get it, we do prioritize people like that in both our IOT and our OAT programs. So we use hydromorphone. We would like to offer heroin, but we haven't been able to get it distributed in Ontario, even though it's legal to do so. Our median daily dose of hydromorphone is 400 milligrams, and those are divided into 2 different doses, at least 3 hours apart. So people end up getting 200 milligrams and then another 200 milligrams. This is equivalent, just so you know, to 50 Dilaudid tablets. So the maximum dose in Ontario for safer supply, I believe, is 30 tablets. And just one dose, well, actually, one dose of IOT is 25 Dilaudids, and 2 doses of IOD is 50 Dilaudids a day. It's equivalent to that. Also equivalent to about 2,000 milligrams of oral morphine or Cadian, and about 4 points of fentanyl, which is like the average street fentanyl. It's about 4% concentration. Most of our patients feel they'd like a higher dose, but the volumes get quite big. We use a 50 milligram per milliliter dilution, and so they need 4 milliliters per shot. They usually end up dividing it up into 2 shots just for the 1 dose. So we've had very good results in this program, and they're in line with the benefits that have been shown in the controlled trials. Patients report street fentanyl use decreased from an average of 7 points a day to an average of 1.4 points a day. 60% of the patients are completely abstinent from street fentanyl. Only half of the clients were on OAT at the beginning. Almost everyone was at the end of when we were doing our assessment. Valid health insurance, so OHIP, went up from 70% to 88%, and 22% improved their housing level, with 50% fewer clients sleeping outside. So we were able to get people into the shelter system, which is not easy to do in Toronto. After our evaluation after a year of the program, we had transferred 38% of people to OAT. 20% of people were still on IOT. 4% had transferred to a safer supply program. A third were off treatment or lost to follow-up, unfortunately, and 3 had died. And they did not, one of them died by suicide, so he had quite severe depression. One of them was a very heavy drinker and died of an alcohol toxicity while he was in the program. And one of them was off treatment and died of a fentanyl overdose. We've also started using sufentanil in addition to hydromorphone in a type of kind of pilot way. So we have about 10 patients on sufentanil right now. For sufentanil, the dosing is different. We use a maximum of 1,000 micrograms per day, which is 250 micrograms per dose, up to 4 times a day. This is equivalent to about 3,000 milligrams of morphine. Sufentanil is a very, very short half-life, so people have to come in multiple times a day, and they won't have any benefit after the hours that our clinic is closed. So we transferred 10 patients in total from hydromorphone to sufentanil, and the people were transferred because they were either having adverse effects with the hydromorphone, or they were just still using a lot of fentanyl on top. Of the people who were still using at the time of the switch, about 70% reduced or stopped their fentanyl use. Patients really like the feeling of sufentanil, but they do say it has no legs because it has such a short life. When combined with the OAT that we give, we're prescribing quite high doses to this cohort. The range of our morphine equivalents was between 3,700 to 5,400 a day. And just to give you guys an idea of what this would mean if we were to give the same amount in methadone and Cadian, it's equal to about 250 milligrams of methadone and 1,500 milligrams of Cadian. So very high doses to stabilize. So we know that IOD is an effective way to reduce reliance on toxic street fentanyl, but we're unable to roll out this intervention to the people in need. The biggest challenge is that the medication isn't covered in Ontario, our provincial formulary. This is an environmental scan of provincial coverage for high potency opioid formulations across Canada. It was put together by Maria Zhang from CAMH and Turner Barrett, who's a pharmacy fellow from UBC. And it basically shows that no provinces cover the highest formulation of hydromorphone that we would really need to get to the doses we need for IOD. Sufentanil is covered only in BC and in the Yukon. And the formulation that we use, this 50 milligram per mil formulation, is covered in quite a few places across the country. except for Ontario, Newfoundland, and the Yukon. And you can see for those people from Ontario today, we are tied with Newfoundland for having pretty much the worst drug coverage for these types of medications. We are winning the prize. The coverage issue prevents rolling out IOD in more locations. The works runs out of one central clinic right in downtown Toronto with very limited hours and limited staffing. And clients essentially have to spend all their days downtown, right by the clinic, in order to access care. If they get housing out of the area, which we want them to do, it becomes very difficult to maintain them on treatment. So the program has the potential to be expanded using a pharmacy model of care, where clients could be titrated in a clinic setting, and then doses could be observed either intramuscularly or intravenously in pharmacies across the province or across the country. But we would need financing of the medication to make this happen. And if we did have financing, then IOD could probably be rapidly expanded. So in the meantime, there are other things that we as clinicians can do starting Monday to help our clients who continue to inject street fentanyl. And this is apart from our first-line medications, which include, as you know, methadone, KDN, Suboxone, and Sublocade. There is a poll question, if we could bring that up. The poll question is, have you ever prescribed fentanyl patches to treat opioid disorder? See if we can get this poll. They may have missed this poll question. Okay, well, let's just say in the chat some yes or no's. Have you ever prescribed fentanyl patches to treat opioid disorder? No. Okay. Thank you, Harvey. Anyone else? Where are my prescribers? My 8 prescribers. Nope. Okay, Victor. In any of your practices, do you see fentanyl patches being used? I've got 2 no's. By clients, yes. Good one. Okay. All right, I'm going to talk about that. All right, so the caveat here is that this is not evidence-based. So we've have looked into this for some, but haven't prescribed it. Okay, so this should be helpful to you. Using fentanyl patches for opiate use disorder, to the best of my knowledge, has not been studied systematically. So this, and pretty much everything I say from here on in, is not evidence-based. But something not being evidence-based doesn't stop us from making guidelines about it. So very handily, the British Columbia Centre for Substance Use has published protocols for using the fentanyl patches as safer supply. These resources are available online, very easy to find, and they include patient information handouts and clinical protocols. I've actually been doing this in my practice for many years, like probably greater than 10 years, just because I've had clients in the past that haven't responded well to methadone, but I am definitely doing it more now with mixed results. So fentanyl patches, the nice thing about them is that they give 24-hour coverage for withdrawal. They also give 24-hour coverage for pain control. And as we know, a lot of our patients do have pain issues concurrently. It's actually difficult to divert or misuse the patches without it being detected. So yes, it's easy to misuse them. You can inject them, or you can chew them or smoke them. Actually, it's probably hard to inject them, but you can definitely chew them and smoke them. You can sell them, but you can't do these things without it being immediately detected. So for me, I think widespread diversion or even minimal diversion is not really an issue with this treatment option. And it's well tolerated. So comparisons between it and Cadian or sustained release oral morphine have found it has a lower incidence of constipation and sedation. And also, thank you for putting the link up, Galit. Also, patients like it because it's called fentanyl. And that is just, it's appealing to people. It has the same name and is the same drug as a drug that has been working for them. So it has its issues. And for me, the biggest one is that it can be very hard to keep stuck to the skin. For opiate dependence, it seems to be required to change more frequently than the product monograph states. So for pain, you change it every 3 days. I have to change it much more frequently for opioid dependence. Some patches stick better than others. In Ontario, we seem to have 2 brands, Teva and Sandoz, and the Teva seems to adhere much, much better than the Sandoz. But unfortunately, the Teva has faced supply issues and is frequently back ordered. So right now, for example, all of my patch patients are using Sandoz, and we're running into problems keeping it attached to their skin. Also, it's not officially covered this is an Ontario thing. In Ontario, it's not officially covered for opiate use disorder. In order to use it, physicians have to assert that it's for the treatment of chronic pain. This is the titration schedule published by the BCCSU. I go quite a bit faster than this schedule, although if you're just starting out, it's nice to have this to stick to. So 1 patch is equivalent to about 200 milligrams of morphine, or about half a point of the average street fentanyl. So for patients that are using 1 gram or more of street fentanyl a day, they probably aren't going to feel the difference with 1 patch. For patients that I know, I'm very sure about what their tolerance is. Usually they're on OAT at the time or some kind of oral medication. I do start with 2 patches, and then I generally go up by 1 patch at a time. So in BC, Dr. Sutherland has reported that the number of patches she uses for her patients range from 16 to 28 patches. These are the 50 microgram patches, which is between 3,200 to 5,600 morphine equivalents a day. This is in line with treating someone who's using about 7 points of average street fentanyl. In my practice, I combine the patches with other OAT and generally end up using between 8 to 10. I have someone on 17 right now with high doses of methadone and Cadian in addition. The patches are really thin and really transparent. Oh, sorry. Here's a slide of a schedule for if people have missed pharmacy visits, which I don't actually find to be a big problem in my practice, but it's a way of retitrating that you can refer to. In my practice, lost patches are more of an issue. They're very thin and transparent, and they're frankly very easy to lose. They get off your skin and they get folded, then they get caught up in your shirt and end up in the laundry or wherever. So I basically put the fear of God in people about losing the patches the first time I prescribe it to them. But losing it does happen, and what happens the first time they lose it, it's usually because they haven't figured out how to keep it on properly, and I give them a second chance. If they lose it again, I don't replace the patch. I replace it with the same morphine equivalents in some kind of oral medication. And if it becomes a repeated thing, I really don't replace them for longer and longer periods of time. If people just can't keep them on and can't keep track of them, then they usually take themselves off the program. It just becomes too much of a pain, and they're not on enough to do a good job in terms of treating their OUD anyway. However, for people that it does work with their skin and they're able to keep it on and keep track of them, I've had fairly good results. So how about when the fentanyl patch doesn't work? So now you've tried methadone, you've tried Suboxone, you've tried Cadian, you've tried Sublocade, you've tried the fentanyl patch, you've tried IOD, nothing is working. And you don't want to try safer supply for your own reasons. So for those whom regular treatments do not seem to work, what can we do? And my mantra is I will try pretty much everything. And also, when I try everything, although I don't do this well, as you will see, I try to dose it all appropriately. So let's do a few case studies. Case number 1, we'll call her Sarah. She's a 34-year-old woman who's living in a shelter hotel. I've known her for years. She's a very, very heavy user. She's tried methadone and Cadian. She's tried Suboxone, it doesn't work for her. She continues to use a very large amount of fentanyl. She tells me she's using half a ball on top of her OAT, and we've restarted her OAT relatively recently, so it's not as high as I would like it to be. She's also tried fentanyl patches in the past, but she was in too chaotic a situation in order to manage them, so it didn't work out. She wants the pill program and to try patches again. She wants to quit needles. So I'm just sharing with you a tool that I use that I made with my nephew, who's just a smart computer guy. It's a morphine equivalency calculator that I use all the time. It allows me to put in points of fentanyl and the percentage of fentanyl from the drug checking information in order to find out the morphine equivalents. And it allows me to put in more than one type of opiate at once and add them all up to see what I'm prescribing. We just sort of made it available online. Use it only if you have good clinical judgment, and it does not account for cross tolerance at all. So you really have to know what you're doing if you're going to use this. But I put it up there if anybody wants it. So Sarah, in December 2023, was on 105 milligrams of methadone, 800 milligrams of Cadian, and was using 17.5, that's half a ball of fentanyl per day. So I was prescribing her the equivalent of about 2,000 milligrams of morphine, and she was using about 7,700 milligrams of morphine on top. So her tolerance for morphine was about 10,000 milligrams. This is about to be a lesson in under prescribing. Remember, she wanted the pill program. So I offered her 6 Dilaudid to be taken observed in the morning with her methadone. I increased her methadone to 115. I increased her Cadian from 800 to 900. So in the period of about a month, I had increased my prescribing about 400 milligrams. Oh, session is supposed to end at 11:25. Okay, thank you. I'll go pretty quickly. So I'd increased her morphine by about 400 milligrams, but she was still using, because that's only 5% of her total need, she was still using the exact same amount of street fentanyl. Not surprisingly, she hadn't changed her use at all. So I decided to be more aggressive, sort of, and over the course of about 4 months, I increased her Dilaudid to 8 tablets in the morning. I increased her Cadian to 1,100, her methadone to 130, and gave her 6 fentanyl patches. So now I had doubled the amount that I was prescribing her to 4,000 milligrams of morphine. And she actually did bring her use down to about 9 points of street fentanyl. Not surprisingly, she was in withdrawal at this because she had come down 2,000 milligrams more than I had gone up. So what I've learned from Sarah is that she would need 300 Dilaudids a day to meet her opiate needs. she has a huge requirement for opiate. As I go up, her use decreases, but I am still dramatically underdosing her. She needs 6,000 milligrams of Cadian and 300 milligrams of methadone for me to get what she's tolerant to. And, frankly, that makes me uncomfortable. But I know she would probably do better if I were to prescribe that. I'm very curious about what people think about these kinds of numbers. If you want to put put what you think about this prescription, which I haven't done, in the comments. But that is what heavy users, that is what their morphine equivalents are. I'm just going to do a couple more cases very quickly. So I have, I'm actually going to skip this case because I just want to make the point that for one client I had, fentanyl patches need to be changed more frequently for opiate use disorder. And for one or two clients, particularly since the Tiva patches have been backordered, I've been changing their patches daily. This one client said that he used much, much, much less on the days that he was getting his fentanyl patches. And indeed, now that I change his patches daily, he has been able to stop using. So they're supposed to be changed every 3 days, according to the product monograph. A more typical guy, 63-year-old man, history of drug use, has tried methadone, hates it. Suboxone didn't work for him. I started him on long-acting hydromorphone and short-acting hydromorphone, both observed twice daily in pharmacy with Cadian 400 milligrams on top. So he's getting a total prescribed of about 1,200 milligrams of morphine. So not as insane as the previous cases that I told you about. So this gentleman did extremely, extremely well. He's not using it all. He's working. He's starting his own business. He's stably housed. And we started giving him take-home doses in the exact same way that I would give take-home doses for Cadian or for methadone. So he leaves urine drug screens. I assess him. He's very functionally stable. He's clinically stable. His drug screens reflect what I'm giving him. He's been great with his take-home doses. His life is much improved. And so what he's taught me is that we can approach take-home doses for other opioid molecules the same way we approach them for methadone and Cadian. There's really no difference between giving hydromorphic contin take-home and Cadian take-home or sustained release oral morphine. And then a final case that I'll bring up before I close is a 31-year-old man who was using street oxycodone for years. And he didn't want to start methadone. He was really adamantly against it, really because of stigma reasons. Suboxone hadn't worked for him. I ended up starting him on controlled release oxycodone because he was getting into all kinds of financial and criminal trouble with his dealers. He's maintained on oxycodone 640 milligrams twice a day, which is an overall morphine equivalent of about 2,000 milligrams. He is still observed twice daily in the pharmacy, but he is doing extremely well. No criminal involvement, highly functional, exploring career options. He pays for the medication himself, which brings me to the last slide. I just wanted to bring up this very interesting program by Dr. Sutherland, which is a paid prescription fentanyl program. The idea with this program is that a fentanyl powder is compounded by the pharmacist. The dose is titrated in a supervised clinical setting. And then once the dose is established, a prescription is given to the patient to fill at the pharmacy like any other medication. But the price for the prescription is set at a cost that's slightly above the street value of fentanyl. So they get clean fentanyl that costs a little bit more than buying the same amount on the street. The idea is that this eliminates the financial incentive to divert the medication. So this could be done with any opioid molecule. It could be done with Dilaudid, it could be done with Cadian. I'm curious about what people think about this. Is it ethical? Do you think it violates any college policies? There's one last poll. If we could get that last poll about, yeah, that's it. What do you think of the idea of a paid fentanyl program? And I haven't given you a neutral option here. So you either have to say you're for it or against it. You don't have to be actually completely for it or completely against it. Just say which way you're leaning. Wow, people are for it. This is interesting. Okay, one person's against it. I'm curious why. All right, keep going, keep going. Let's get a few more answers. I've got 6 people answered. Oh, somebody changed their mind. Don't get peer pressured. We don't know who's voting. It's anonymous. Most people that are voting are for it. Okay, we have 2 minutes for questions, if anyone has. Please give me questions in the chat. Thank you, Lauren. Sorry, I know I did go a little bit long and rushed through the end. If you don't have time to stick around and give questions in the chat now, you can reach me on the networking function if you want to discuss any options. Wow, people are very into the paid fentanyl program. That is so interesting. The street fentanyl morphine equivalent calculation comes from, it's basically the equivalence between IV fentanyl and oral morphine, but it's using, the ones that I've given have been using 4.4, which is the average amount of fentanyl that's been found in the Toronto street supply. So if that number is variable, so you would have to adjust the calculation if you know that the fentanyl in your area is 15%, or if you know that it's 2%, you would have to adjust the calculation based on that. But it's based on street fentanyl that was, yeah, it was from Toronto Drug Checking. No problem. And the calculator that I showed the link to allows you to change that percentage quickly. So you can put in 15 in case it's stronger. Yes, the question is, as folks are pulling off fentanyl, are you finding you need to co-prescribe benzos to account for the current supply? Absolutely. Surprisingly, I don't need to prescribe them that high or for that long. Like, I found that people do well with a fairly short taper of clonazepam generally. Sometimes people do need to go longer, but it hasn't sort of ended in a whole bunch of people with me that are on chronic benzo prescriptions. So I'm usually able to do it for a short period of time. But yes, I always ask people when they're stopping fentanyl to look for the withdrawal from benzos and sort of talk through with them how that might feel different than opiate withdrawal and what they need to look out for with that. All right, well, have a great rest of the conference, everybody.